Hello, welcome, and thank you for joining us for today's webinar, Optimizing Population Health for LGBT People in Patient-Centered Medical Home. My name is Melissa De Silva, and I'll be acting as your moderator. This webinar is a production of the National Healthcare for the Homeless Council. It is made possible by a grant from the Health Resources and Services Administration in the Bureau of Primary Health Care. This is a 1-hour presentation with the last 10 minutes reserved for Q&A. Again, thank you so much for joining us for today's webinar, Optimizing Population Health for LGBT People in Patient-Centered Medical Home. Our presenter today is Dr. Harvey Macadam. Dr. Macadam is Director of the National LGBT Health Education Center at the Fenway Institute, a division of Fenway Health, a federally qualified health center in Boston. He is also a member of the Division of General Medicine at Beth Israel Deaconess Medical Center in Boston, where he has had a primary care practice for over 25 years and served as VP of Medical Affairs. He is Clinical Professor of Medicine at Harvard Medical School and the LGBT Advisor in Harvard Medical School's Office for Recruitment and Multicultural Affairs. And if that weren't enough, Dr. Macadam is also an author and editor of several publications and a recipient of numerous service and achievement awards. And with that, I turn the mic over to Dr. Macadam. Thank you.
Thank you, Melissa, and thank you for all of you for joining today. Our topic today is, as Melissa mentioned, to talk about population health and patient-centered medical homes, which is clearly an important topic for community health centers as we begin to prepare for some of the changes of the Affordable Care Act. Our work is also supported through the Bureau of Primary Health Care of HRSA, and the National LGBT Health Education Center does work with community health centers through collaboration with groups like the Healthcare for the Homeless Council. We do education, training, and technical assistance. We also do work in academic medical centers and consultation with health centers for strategic change, specifically around the issues we're talking about today. So we're very pleased to be able to do this program. The key points for today's session are, first, we want to focus on some of the concepts of population health, which we think are key to some of the changes that are going to improve quality of care and decrease cost of care in the future. That's going to be very critical for the success of patient-centered medical homes. I'm going to talk a bit about why we're focused on LGBT health as one of the topics, and then talk a bit about LGBT demographics and focus on overcoming barriers to change, but also creating systems and environments for care that allow us to appropriately provide population health in patient-centered medical homes. Population health is a concept that has been talked about for a long time, and I just wanted to review some of the basic components so that we all are thinking about it in the same way. It's been defined as, rather than looking at individuals' health outcomes, looking at the health outcomes of a group of individuals, including the distribution of such outcomes within the group. And it's a major step to achieving this aim is reducing inequities among population groups, which is really the focus of a lot of the community health movement that all of us are involved in, is to eliminate health disparities. Population health, though, also seeks to step beyond the individual level focus of mainstream medicine and public health by addressing the social determinants of health and improving the capacity of people to adapt to, respond to, and control life's challenges and changes. And as we'll see in a minute, a lot of this happens outside of not only academic medical centers and community health centers, but out in the community where we have to begin to do work to really understand population needs. So first I said I was going to spend a few minutes talking about why our focus on LGBT health. Well, the reason for that is that a number of studies have demonstrated healthcare disparities among lesbian, gay, bisexual, and transgender people, which generally stem from bias in healthcare, stigma and discrimination, both on an individual level and on a societal level, and the social determinants of health, which affect all people, but in some ways disproportionately affect many LGBT people. The healthcare disparities, which I'm going to briefly summarize, have been described in two recent federal publications. On the left is a photograph of the book put out by the Institute of Medicine last year, a study of the health of lesbian, gay, bisexual, and transgender people, which really details very carefully many of the health disparities which have been studied in this population and recommends a research agenda for change. Healthy People 2020 on the right is a publication that the Surgeon General puts out every 10 years, and this was the publication put out in 2010, which for the first time detailed LGBT health disparities and issues which they felt needed to be corrected in order to improve health among LGBT people. We've actually recently put on our own website for the National LGBT Health Education Center a publication which summarizes these health disparities and summarizes a lot of what we're going to be talking about today in terms of understanding these and overcoming the barriers that we need to eliminate these disparities. But the main issues of the publications about health disparities is that they exist across the life cycle. They affect young people, old people, people of all ethnicities and races, and that LGBT people are a very diverse group of people. Some of the key disparities which are highlighted in Healthy People 2020 include issues among youth who are 2 to 3 times more likely to attempt suicide, and very relevant to healthcare for the homeless settings, are much more likely to be homeless. 20 to 40% of homeless youth are LGBT. LGBT populations, including youth, have the highest rates of tobacco, alcohol, and other drug use. Gay men are at higher risk of HIV and STDs, especially among communities of color. And later on in the talk, we're going to use this as a specific example of an area that we can target to develop focused programs to improve quality of care and decrease the cost of care while dealing with a major public health issue, HIV and AIDS. Lesbians are less likely to get preventive services for cancer. Lesbians and bisexual females are more likely to be overweight or obese and lead to other areas of risk for other diseases like cardiovascular disease. I think an important population that we need to consider are transgender individuals, which are overly represented among healthcare for the homeless programs and have a high prevalence of HIV and other sexually transmitted infections, violence, and are victims of violence, behavioral health and mental health issues, as well as suicide. And they're also less likely to have health insurance than heterosexual or other lesbian, gay, bisexual individuals, making it harder for them to access health care in places other than community health centers. Finally, elderly LGBT individuals face additional barriers to health because of their isolation and lack of social services, as well as culturally competent providers who really understand the needs of LGBT elders. In terms of LGBT demographics, concepts, and terminology, I think one of the most important issues for us to understand is that the acronym LGBT really does not reflect the great diversity in this group, and that when we're speaking about lesbian, gay, bisexual, and transgender people, we have to recognize that they really are a very diverse group, as I said before, representing all socioeconomic strata and various racial and ethnic groups, so that we do not have a homogeneous group of people. Turning now to some of the health policy issues that we're going to focus on, the Affordable Care Act has clearly provided new opportunities as well as challenges for health centers, as many health centers seek to transition from being traditional community health centers to patient-centered medical homes. And I know many health centers are in various states of transformation and are looking at many different aspects of what it takes in order to do this. And we're going to focus on one example today, but we'd be happy to talk about looking at others with you either after the talk or in the future. I do think that one of the challenges that we're all going to have to deal with as part of our transition is the fact that the Supreme Court has said that the Medicaid expansion, which was supposed to be part of the Affordable Care Act, is no longer going to be mandatory. And this is a map of the 50 states demonstrating which states have committed to participating in Medicaid, expanding Medicaid, which would allow, for example, single individuals to get Medicaid coverage in the future and not just limit ourselves to the current categorical groups that get Medicaid coverage. So that we see that in many states there will still be a large number of people who are under 133% of the poverty level who will not be able to get access to Medicaid unless these states ultimately change their minds. But this is an additional challenge for health centers under the Affordable Care Act as we begin to see more and more people coming for primary care. When we look at the core standards for patient-centered medical homes, we can see that these are the core 6 that health centers are looking at, but that of these, 2 of them are particularly important when we think about LGBT people. The first is identifying and managing patient populations, which I highlight because often LGBT people are invisible to their healthcare providers unless they're asked specifically to talk about their sexual orientation or gender identity. And then secondly, to plan and manage care, which again, without knowing more about the population we're caring about, we can't develop appropriate systems to provide care. And we're going to use HIV in young MSM as an example of that in just a minute. So now we're going to turn to overcoming the barriers to change that I think are important for us to consider and talk about so that health centers can make the transition to care for LGBT people in the context of patient-centered medical homes. At this point, though, I wanted to do a little exercise where we ask you about your experience with healthcare and then talk about how it might lead to invisibility in care for LGBT people. And I'm going to turn this over now to Melissa for a minute to ask a few questions and see what you have to say.
Thanks, Dr. McAdin. So, folks, we're about to issue 3 polls. You see 3 questions on the slide right now. How many of you have ever been asked to discuss your sexual history during a primary care visit? Has a clinician ever asked you about your sexual orientation? Has a clinician ever asked about your gender identity?
Thank you, Melissa. I think as you can see that this is actually compared to other groups, about 50% have been asked to take a sexual history, which compared to other groups that I've talked with is probably more than average, but nevertheless reflects the fact that still in this, even among those of you who are on this call, 50% of your clinicians don't ask you anything about your sexual history. When we get to issues around sexual orientation, just more than a quarter have been asked about their sexual orientation, which means that a lot of people who may be lesbian, gay, or bisexual go to their primary care clinician and really never have a conversation about these issues with their clinician unless they bring it up themselves. Although I do know people who have brought it up and then have never had that issue followed up by their clinician during the visit. And then finally, for transgender people, you can see that no one here has been asked about gender identity, which is not surprising because I think this is not something which is taught about much in any kind of health professional education. But nevertheless, if you're a transgender person seeking care, you can see that you need to either be very assertive on your own to engage clinicians to discuss your needs, but that we can't rely on the current way that we receive health care in order to understand the needs of populations that we're caring for. And that if we are going to do population health, we have to do more. So I wanted to talk a few minutes about that, and first ask the question, how well do you know the people coming to seek care at your health center? And then secondly, how do you go about finding it out? And how do we distinguish between new patients and people who may be new lesbian, gay, or transgender patients? In answering that question, I think first I just want to raise a point, which is that we do need to understand how clinicians and staff feel when they learn this, because I think one of the barriers to getting clinicians more involved is that they don't feel like they really understand these issues, and they feel as if sometimes that they're not relevant to care, but that if we understand the disparities that we're talking about, we get a greater sense of the relevance, and that people feel concerned about discussing intimate issues. But we should be thinking not just about what clinicians should be doing, but what can be done to improve the patient experience through both clinical interactions, but also through systems which allow us to do things in addition to what happens in the clinician's office. At the Fenway Institute, we've developed these two monographs, which we have available on our website. Why gather data on sexual orientation and gender identity in clinical settings, and how to gather data in clinical settings. And I'm going to spend a few minutes talking about some of these issues. In terms of why, we believe that it increases our ability to screen, detect, and prevent conditions more common in LGBT people. It helps develop a better understanding of patients' lives. And it allows us to compare outcomes with national surveys of LGBT people, but it also allows us within our health center to compare the kind of care that LGBT people are getting with the kind of care that heterosexual people may be getting. So that, for example, if you want to compare, access to preventive care, you can actually do those kind of studies, but you can only do that if you've identified LGBT people as a population group that you're taking care of. And this is the beginning of what we need to do to practice population medicine. I think finally, people are going to feel much safer discussing their health and risk behaviors, not only once they've disclosed this information, but even if they're asked this information, it gives them an indication that you're open to talking to them about their sexual orientation or their gender identity and intimate issues that they may never have talked with many people about before. So that it begins to create an environment that's much more welcoming and inclusive for care. We think that the process of gathering this information can be done on the left-hand side of this slide at home. A lot of health centers are now implementing electronic systems with patient portals, and people can input this information in the privacy of their home, or they can input it electronically at registration or on a paper form. And some studies have actually shown that people are much more willing to enter intimate information into a computer or onto an iPad than they are by talking to a registration person. Then when someone gets into the provider's office, the provider can follow up on this information and ask additional questions and ultimately enter this information into the electronic health record. Now, this is not currently a meaningful use requirement, although it has been recommended that it should be by the Institute of Medicine and by the Secretary of Health and Human Services. So we do hope that in the future there will be more, this will become more routinely part of healthcare systems in all healthcare settings. At the Fenway, which is a health center in Boston, which is where the Fenway Institute is located, we do routinely ask this question about sexual orientation as part of our demographics. So we ask people whether they're lesbian, gay, or homosexual, straight or heterosexual, bisexual, something else, or don't know, giving people the option not to commit. And obviously people have the option of voluntarily not answering the question at all. But again, we think it's important to ask this information so that we can evaluate how well we're doing in caring for our LGBT patients. We also have to recognize, though, that sexual orientation is not just an issue of identity, but also behavior and attraction, and that is information that isn't necessarily appropriate to be asked in a questionnaire at registration, but may be something that can be talked about by the provider, or even through additional history which is provided to the provider on paper. Now, in terms of collecting demographic data on gender identity, these are some suggestions from the Transgender Center of Excellence in San Francisco to ask about what is your current gender identity, and then there's a number of choices: male, female, transgender male, trans man, transgender female, trans woman, gender queer, or other categories that people might specify, because there's lots of terminology that people use who are transgender. And also, what sex was someone assigned at birth? So if they have transitioned from one sex to another, that we have some record of what their birth sex was, which also can be important in determining how to do an appropriate examination on somebody. And then finally, what pronouns and name does someone like to be called, so that when someone comes for care, they're addressed appropriately in all aspects of care, beginning from the time they arrive until they depart from the health center. So these are the things that we think are increasingly important to provide appropriate care for transgender people and other gender nonconforming people. And again, we can talk more about this during the question and answer period. Now, as I said, clinicians are still very much an important part of the process of care, and we have to think about what happens in clinicians' offices. This study was interesting in the sense that it was a study of what doctors talked about with a group of HIV-positive patients, and showed that 84% talked to their patients about antiretroviral therapy, but only 14% talked about HIV transmission and more intimate issues related to risk reduction. This led the Institute of Medicine to say that ironically it may require greater intimacy to discuss sex than to engage in it. And indeed, discussion of sex is something that doctors have not traditionally done, and I think this was demonstrated by the poll that we did earlier in this presentation, and that as we're teaching clinicians about caring for LGBT people, we're also working with medical schools and schools of nursing and schools for other health professionals to really work on improving the curriculum so that people do begin to get at this kind of information during clinical visits. Clearly, the core of doing so requires that we talk to patients in a cross-culturally appropriate way, using respect, empathy, and curiosity, and being guided by this, and recognizing that if we're genuine in these things and we're appropriately curious and not just arbitrarily curious about what we're asking, that people generally feel comfortable answering questions, particularly if they're put in the right context. So when taking a history, I think our basic issues are that the core comprehensive history for LGBT people is really the same as for all patients, recognizing that there are unique health risks and issues, as we discussed earlier, that it's important to get to know our patients as people and understand who their partners, children, living circumstances, and professional lives are like, and use inclusive and neutral language so that, for example, instead of talking about do you have a wife or husband or boyfriend or girlfriend, ask do you have a partner or are you in a relationship, and what do you call your partner? It's a different way of getting at the same information, but it avoids giving anyone the sense that you're making any judgments or presumptions about them before they've had a chance to talk to you about their personal lives. It's also important that when we're taking a sexual history, we make it routine, as I've said, make no assumptions, and also recognize that this is not equated with learning about sexual health, which is also important, and it's also not equated with all of LGBT health, because there's more to LGBT health than just issues related to sexuality. And that, but when we do take a sexual history, it's important that we talk about behavior and risk, asking questions like, have you had sex with anyone in the last year? Have you had sex with men, women, or both? Have you had oral, vaginal, or anal intercourse? Learning about the number of partners people had and how often they use condoms, whether they've exchanged sex for drugs, alcohol, housing, food, or money, and whether they've ever been forced to have sex, to give doctors a sense and nurses a sense of whether or not people are at high risk for sexually transmitted infections or HIV. And again, we have to remember the importance of talking to people about sexual health. And then also, we have to remember to ask people about gender identity, recognizing that this is a complex issue due to the fluidity of expression, which we talked about earlier, but that in clinical settings, the provider can ask if a patient has questions about gender identity, and hopefully that will be a sign that this is an appropriate time for people to bring up issues that they want to discuss. Most importantly, when caring for LGBT people, while many of their concerns are similar, I want to reiterate what I just said a few minutes ago, is that the issues are not just about talking about sexuality, but that we have to be thinking about talking about families and coming out, long-term relationships, reproduction and parenting, mental health issues and behavioral health issues, violence, both domestic violence and other hate crimes, which LGBT people are at high risk for, chronic diseases, and communicable diseases. and that, this is what will allow us to provide rich care for LGBT people in primary care settings. Now, when we get to developing clinically and cost-effective clinical practices, I wanted to use as an example developing HIV prevention programs in primary care as an example that we could talk about today. So first I wanted to start off with a little background. As many of you know, the initial approach to HIV and AIDS in this country was that counseling and testing was often provided separately from primary care sites which did care and treatment. So counseling and testing sites were funded by one funding stream, and primary care was funded by other funding streams. And these two processes, all of which probably should have been or could have been done together, were often separated, often in different organizations, and not even done in the same site. As we look to the future, with the shift in leadership and roles within the continuum of care in the context of health reform, we can see in the center that the traditional focus of hospitals within the care continuum has really been providing acute care, but that increasingly the kinds of things that we can do in community health centers, such as prevention, primary care and coordination of care, urgent care, housing and shelter, patient navigation, case management, and outreach, are the kinds of things that will allow us to combine prevention, care, and treatment, and also be the ones who really provide the glue that ensures that people get cost-effective and high-quality care. And I think sets the stage for us doing effective HIV prevention in addition to HIV care. Specifically drilling down and looking at HIV in the United States, this pie chart shows the most recent data released by the CDC, which was released in the fall of 2011 and is the data from 2009. And as you can see on this, the number of people who have HIV in 2009, 64% of those were men who have sex with men, many of whom would identify as gay men. 27% contracted HIV through heterosexual contact, and 9% through injection drug use. But 64% was a much higher number than people had been thinking it would be, and suggested our need to focus on what were the issues among men having sex with men and gay and bisexual men in terms of what we needed to do to try and impact HIV and prevent new cases of HIV in this country. When we looked at that number, and in this case the Centers for Disease Control included among the category that they called men who have sex with men, transgender women. So it includes that group, which is very high risk for HIV. But the incidence among young black men who have sex with men ages 13 to 29 increased by 48% between 2006 and 2009, which is a really dramatic increase that was quite unexpected by many clinicians and has led many people to really look carefully at this group. In fact, at the recent International AIDS Conference in Washington, this was a major area of focus. It's important that when we think about this, that we understand that sexual risk behaviors and substance use do not explain the differences in HIV infection between black and white MSM, but that the most likely causes of the disproportionate infection rates were the low frequency of HIV testing, due to the poor access to testing and counseling. The high prevalence of HIV among individuals in black communities and black men who have sex with men, including gay, bisexual men, and transgender women, would be in contact with, the high prevalence of other sexually transmitted infections which facilitate HIV transmission in this community, and again, the barriers of access to care. As I mentioned earlier, transgender people have much lower rates of health insurance than even LGBT individuals, and therefore access to care is extremely important. I think that in recent trial results that were just reported, that was a study of over 1,500 black MSM, some of the important results were that of those who were infected both previously and during the course of the study, individuals who identified as gay were more likely to be infected than individuals who are HIV negative. This is probably because these individuals lived in communities where there were higher rates of infection among those who they had intimate relationships with. It's also important to note the difference in terms of unemployment status and housing status in terms of individual and income, in terms of individuals who are HIV infected versus those who weren't. So again, these are social determinants of health which are very important for us to consider as we're trying to understand what we can be doing to decrease the incidence of HIV infection. So I just wanted to outline a few steps for building a program for effective HIV prevention. First, we need to think about outreach, counseling, and testing. So we need to be able to go out into the community and find people who may not identify as gay, but may be engaging in same-sex behavior, which might put them at risk for HIV, or people who may identify as gay but may not have traditionally had access to care, and bring them to get counseling and testing so they can learn their HIV status and then be cared for appropriately. We need to think about how to integrate prevention with care systems and improve the knowledge, attitudes, and skills of healthcare providers, as well as systems for care, as we've been talking about. We have to think about how to retain people in care so that peer navigators and case management are all very important. And then finally, we need to ensure regular follow-up. I want to bring your attention to this triangle over here on the right, which shows that out of more than 1 million people in America who are infected with HIV, only 80% know they're infected, which means that we really need to do a better job with outreach, counseling, and testing. And that even though of those 80% who know they're infected, we drop down almost another 20% in terms of people who are actually linked to care, and another 20% to those who have actually stayed and been retained in care. And ultimately, only 28% of those in the country who are felt to be infected are being effectively treated now with antiretroviral therapy, which we know can not only help individuals live longer, but if they're treated so that their viral load is non-detectable, they're very unlikely to transmit infection to other people. So that as we think about what we need to do in patient-centered medical homes, we need to think about developing these systems, but we also have to think about how to create environments that are affirmative and inclusive for caring, learning, and working in our health centers across the country. And some of the things that we need to do are very basic. we could probably make this list 10 times longer, but just to highlight a few issues, I guess I would ask, are clinicians and staff in your health centers being taught actively about the health needs of lesbian, gay, bisexual, and transgender people? Do LGBT employees feel respected and safe at work? Because they're often very important people in ensuring that these kinds of systems of care work for other patients coming to get care. Do forms that are used in the practice or the electronic health record reflect the full range of sexual and gender identity and expression? Is there non-discrimination policy inclusive of sexual orientation and gender identity for patients and staff? And do you have educational brochures on LGBT health topics that are available? A brochure lying on the table which shows a same-sex couple on the cover is very important sign to individuals coming to get care that this is indeed a welcoming environment. And finally, are there individual restrooms or unisex bathrooms where a transgender person would feel comfortable using the restroom in the facilities so that they're not embarrassed in any way and that they feel welcomed by the environment in which you're providing care. These are some of the changes that we've made in Fenway and are being made in both health centers and hospitals around the country, and I think that as you have opportunities, there are things to consider. So I think that in terms of implementing change to proceed as a patient-centered medical home, we have to think about the elements of population health, and as I hope I've described effectively, we need to define and identify populations in ways that we've discussed. We need to understand unique health issues, and obviously in the case of LGBT people, there's much more research to be done. We should learn about the hotspots where there's high variation in practice and high cost, where we can lower the cost of care by developing better systems, using best practices in terms of quality and cost. And I think in the area of LGBT health, some of the areas that are these hotspots are transgender health care, behavioral health care, HIV prevention, which we just talked a bit about, and care, as well as health care for the homeless in general, because I think these are populations that can be very effectively managed in primary care settings, but we have to have the right kind of systems for doing this. We have to have the right education for providers for doing this. And I think that all of these things require work, but they really require that there be champions for these efforts within health centers. Our challenge is really overall making healthcare a right for LGBT people. It begins with greater understanding and research, and this can be done by epidemiologists, but it could also be done in our health centers by learning about who our LGBT people are, and this is part of what we just discussed. And then that leads to our doing appropriate clinical education for staff, as well as education for consumers, which helps them understand that we know about their health care needs and that we're eager to provide it for them. And this really is what makes a health center into an effective patient-centered medical home, when we develop systems for care for populations that focus on quality and cost. So I appreciate the time you spent with us over the past 45 minutes. I just want to remind you that the National LGBT Health Education Center at the Fenway Institute works very closely with the National Healthcare for the Homeless Council. We're here to help you, as well as Melissa's whole staff, and we're really eager to work together to talk with you about these issues and to work with you in the future. Thank you very much.
Thank you, Dr. McAdin, and thank you all. You're all still hanging in there with us for this presentation. No one's dropped off. but also no one's entered a question for us. So at this point, I think maybe I'll go ahead and talk a little bit about our upcoming trainings. So as Dr. McAdam mentioned, he will be participating in our upcoming trainings in Orlando, Florida, November 1st and 2nd at our national conference in March of 2013, and at our last regional training in Newark, New Jersey in May of 2013. So please visit our website. We usually have upcoming events listed under latest news on our homepage at www.nhchc.org. With that, I was hoping that someone would enter a question, but still none, so I'll move on to resources. These resources are also available on our homepage, on our website, and you can access them from one of our resources menu items, heading items, and I believe there's also a resource slide for Fenway Institute on their homepage. Sorry, a resource listing for Fenway Institute on their homepage. So we have a question, and John Hannay asks, what are your recommendations for providers to address mental health challenges and risk experienced by LGBT people as a result of social stigma?
Thanks for asking that question, because I do think that stigma and discrimination are the cause of many of the health disparities experienced by LGBT people, and perhaps one of the greatest of those is reluctance to actually seek care, because I think one of the places that has often been most stigmatizing has actually been have been healthcare settings. So I think as health centers begin to think about behavioral health and behavioral health for LGBT people and helping them access that and get appropriate assessment for issues that people have been concerned about, people will begin to realize that some of the things and anxieties or fears they've had over the years are things that actually can be dealt with. Often stigma and discrimination really leads to very common and treatable conditions. I think sometimes, obviously, stigma can be severe and result in minority stress. But again, with appropriate attention and recognition, these things can be dealt with. I think that dealing with this starts with our first asking people in an appropriate way about their sexual orientation and gender identity. I think that gives them an indication that we're interested in dealing with these issues, and that my own experience has been that after talking with patients about this in my office, that many people will really just comment and say, I've never had a clinician that's actually asked me about this before. And I think this is borne out by the survey we did earlier in the talk. I also think that many times I would talk to somebody in my office, and they would bring something about their life up regarding their sexual orientation or their gender identity. And I basically would spend the whole first session just talking about that, because for them, this was the most important thing that they came for, even though it's something that they hadn't anticipated dealing with, but that so few clinicians ever really talked to them about it. They're eager to sort of figure out, how to begin to approach some of these issues. So I think we can make a big difference just by simply addressing some of these issues, referring people for appropriate counseling when it's necessary. Sometimes medication may be necessary, in which case I would, certainly consult a mental health professional. But that generally these are things that where we can make a huge difference in people's lives by addressing the impact of stigma and discrimination.
Thanks, Dr. McAdam. We also have a question now from Sarah, and she's interested in your thoughts on adding questions on sexual orientation and gender identity into their electronic health record?
Well, this is as I indicated in my talk, I think this is a very good way to begin to ask people information about these issues, partly because it makes it part of your healthcare system and gets into your healthcare record, which allows you to kind of study people. It gives a sign to people that you're interested in these issues. Different systems at this point allow people to modify them more easily than others. But it is noteworthy that the Institute of Medicine, which is a group in Washington that's part of the National Academy of Sciences, is about to have a workshop on this issue to try and get information from consumers as well as vendors of electronic health records and health information systems on what can be done to modify systems. There's some hope that this will be a requirement of meaningful use, which would mean that vendors would actually have to add this in order for their systems to qualify for meaningful use reimbursement from the federal government. But I think at the moment there are, you can do this without having it in an electronic record, but just using paper forms if that's what you're using, or again, working with your vendors. I also think, though, that this has to be supplemented by educating your staff on how to take an appropriate history from people, which includes the sexual history, but also deals with the various aspects of sexual orientation, identity, behavior, and desire, and also talks with patients about gender identity.
Thanks, Dr. McAdam. We have probably our last question for this session from Hunter. He's coming from a behavioral health setting, and his question is, what unique issues in clinical engagement have you encountered, and what strategies have you used, I guess, in working with people who are transgendered, particularly among homeless populations?
Well, Hunter, I think that's a very important question. I do not work in a homeless healthcare setting. I've talked with a lot of colleagues who do, and actually in several of our trainings we brought people whose experience has been in taking care of transgender people. We, do work closely. I don't know where you're located. I know in the Boston area there are a fair number of therapists of different types, social workers, psychologists, psychiatrists, who have special expertise in dealing with issues of transgender people. If you're not working in such a community, again, I think the basic principles are not that different from what I discussed earlier, which is that, transgender people are often people who have experienced obviously a significant change in their lives at some point, but also stigma and discrimination along the way. I think there are also people who have been, in many cases, almost traumatized by the mental health system, though, because older rules about transitioning from one gender to another or affirming one's gender have really let people be almost reluctant to seek mental health professionals. So I think that in recommending behavioral health interventions of any type, we have to be extremely clear that people are going to be sensitive to the needs of individuals and that they understand how to provide affirmative behavioral health care in a way that's very patient-centered and yet based in the reality of what we know of the kind of behavioral issues that transgender individuals have experienced.
Thank you, Dr. McAdam, and thank you all again for joining us for today's webinar. Optimizing Healthcare for LGBT People in Patient-Centered Medical Home. Please visit our website and reach out to us with any questions or requests for additional information. And of course, visit us at one of our regional trainings and our national conference in March of 2013. Thank you all so much for joining us today, and wish us for a lovely afternoon.